Hello and welcome to this eCancer education programme which is being held after the Prostate UK Roadshow. We're here in London. My name is Heather Payne. I'm a clinical oncologist in London, and I'm joined by my colleague Netty Kinsella, who is a consultant nurse specialist at the Marsden Hospital. Netty, we've been talking a lot this evening about quality of life, and I think it's relatively easy and established to measure quality of life in clinical trials, and we have the FACT-P scoring system, the brief pain inventory, and we ask so many patients to fill in these forms, and we can compare the results as they progress on different treatments and compare them between treatments. But I don't know about your clinics, but I think it's just too busy to be able to give very complicated forms to every patient. And, you know, sometimes if we ask for lots of data, it's very difficult to know how we're going to deal with that.
Yeah, I think you're right. You know, there are so many of these forms around, and actually narrowing down the ones that are going to be useful in a clinic, and actually that the patients are going to have time to fill in. I mean, we have, you know, 70 odd patients in a clinic, and obviously there's plenty of time to do that in a waiting room. But I think some of these tools are actually really quite complicated, and spending the time with people going through them is actually one of the most useful things you can do. I mean, you said yourself, you know, 70 patients in a clinic, unless it's inside a clinical trial where you've got research nurses and others that are looking at this information and actually looking back at this information, I think it's quite difficult to keep track. And, you know, who has an IT system that will flash up that last time the patient had an anxiety and depression score of 4, but now it's 9? I think there are simpler tools. I mean, in the UK, obviously we're used to using the holistic needs assessment, but I think there are some things that it probably doesn't characterise well. It was built initially as a very chemocentric review of a patient's progress, and you know, I'm not entirely sure nowadays with the changes in treatment and the kind of better or less invasive treatments that we have, and you know, side effects being lessened by the types of treatments we have on offer, whether actually they're, you know, as accurate or as useful as they used to be.
I mean, quality of life is paramount to men with advanced disease, and I think it's really hard to measure it and to predict what's going to be important for any one individual. And I think especially when you're coming to choosing different treatments, and for example with first line sort of castration resistant prostate cancer, and I mean in my clinic, I guess we sort of go through a little list, and we think obviously we want to offer patients treatments that are going to increase overall survival or radiographic progression free survival, but also to allow men to live and not just exist. And so I think that increasingly we're asking patients about some of the important quality of life issues, and asking them about things like depression and cognitive function, and perhaps interference with sleep and appetite. What do you think the important quality of life issues are?
Well, I think I'm totally going to steal your idea that you talked about earlier, which was basically, let's think about you as an individual patient, your top 5 things that, you know, your quality of life is all about, and actually measure those, because that's really simple. And some kind of visual analog scale that suggests, you know, where they are on that scale that you can actually look at each time is brilliant. I mean, there are so many quality of life factors, and I think it would be wrong for me to define what the important ones are. I think you're quite right. It's all about the patient, whether that's fatigue, whether it's pain, whether it's more about other lifestyle things that they can do as a result of having a better quality of life. But the most important thing is that they define those and not us.
Absolutely, because I think it's very easy to predict what we think should be important. But sometimes you're actually quite surprised when people tell you the things that they would like to maintain in their lives.
Yeah.
And I think we are in a very fortunate place with advanced disease in that we now have a number of different medicines, both with chemotherapy and the newer hormonal agents, that we can match the predicted side effects with the way that patients want to continue to maintain their lifestyle.
Yeah.
So I think it's a bright future.
Absolutely. I mean, I have in the back of my mind a patient that I looked after about 8 or 9 years ago who was 91, and his main raison d'etre was to be able to have a good intimate relationship with his wife, who was about 15 years younger. I think it's a really good reminder that actually, you know, you really cannot tell from looking at someone what's important to them in terms of their quality of life. He wasn't in the best of health. He wasn't as mobile as he would like, but actually that was his number one on his list of quality of life items. And it was really important for us to be able to accommodate that in terms of his treatment plan. Personalised medicine.
I think that's the ultimate personalised medicine,
absolutely.
isn't it, really, to maintain sort of quality as well as quantity of life. And I am actually going to try this idea and go back to clinic and ask people for their 5 top quality of life issues and then start measuring them.
Absolutely, I'm with you.
Well, thank you so much for joining us this evening to think about quality of life, which must remain the pivotal reason for treating our patients. And thank you very much.